So first of all, Happy New Year, everybody, and good evening. We are into the Asia Pacific Geriatric Oncology Society Tumor Board 6, and we are hoping to start with a bang this year. So I welcome everybody to this tumor board, and would now want to handle it to. We have two moderators today, Dr. Bipinesh and Dr. Akhil. So please, the floor is yours.
Yeah, thank you, Dr. Prem. So I think we can start with the case as we have most of the faculty here. So
yeah, sure.
We have tried to keep the case as simple and the approach as we do in the OPD with the time constraints, so that we can have a more practical discussion. Kumar, Prabhat, you can start, Dr. Kumar.
Dr. Prabhat, are you able to share?
Sir, I am not able to share. Just a minute, sir.
Yeah.
Sir, is my screen visible, sir?
No, not yet.
Yeah. Okay, Sophia, I was going to tell you. Are you sharing it?
Sir, we will share the screen from our end. You can just stay next whenever you want us to move to the next slide.
Okay.
That will be fine. I think we can.
I think I have shared so that there is no issue.
Okay, fine. Okay, that's.
Yeah. So yes.
Good evening. Good evening, respected seniors and faculty members. Today I will be presenting the case of a 73-year-old male with presented to OPD with complaints of hematuria since last 3 months. Patient had a past history of TURBT outside, which was suggestive of T1 and high-grade urothelial carcinoma. The MRI pelvis was done here, which shows urinary bladder mass, T3 lesion with extravesical spread. Virat score is 5. There is left posterior lateral wall with left VOJ involved and mild left hydrouretronephrosis. On cystoscopy and TURBT suggestive of recurrence, that was muscle invasive bladder cancer. He had a history of hypertension since last 5 years and on telmisartan 40 milligram OD. Patient also had a history of CVA, left MCA infarct 1 year back on ecosprin and clopidogrel. Current power in upper and lower limb is 4/5. Next, sir, please. On workup, the hemoglobin is 9.1 after 3 PRBC transfusion. The anemia profile, serum folic acid is 5.5 nanogram per milliliter. The lower limit of normal is 8.2. Serum transferrin saturation was 5% and serum ferritin is 12 nanogram per ml. Serum creatinine is 1.4. DTPA GFR is 45 milliliter per minute. Left kidney negligible cortical tracer uptake and USG KUB shows cortical other routine labs are within normal limit. 2D echo was done, which shows left ventricular ejection fraction of 56%. So coming to the geriatric assessment part. In geriatric assessment, general details, patient is pharma by occupation with good social support. On anthropometric evaluation, the height is 153 centimeter, the weight is 58 kg and BMI is 24.78. The clinical frailty score is 4 and G8 score is 8. Now coming to the nutritional assessment, his BMI is 24, MNA score is 18, physical function, instrumental activity of daily living score is 4. There is history of spontaneous fall. Times up and go score is 17. Psychological GDS score is 3. On cognitive assessment, mini-mental stress examination score is 27. There is 4 by 10 numerical rating scale on fatigue. There is on polypharmacy history, 4 medicine per day. In vision history, cataract surgery 2 years back, but no difficulty in near or far vision, and there is no hearing impairment. Coming to the CARG score, positive score is anemia, age more than 72 years, polychemo, full dose, GU primary, and history of poly in past 6 months. Polychemotherapy full dose 14 to 90%, polychemotherapy reduced dose is 12 to 82%, monochemotherapy full dose is 12 to 82%, and monochemotherapy reduced dose 10 to 72%.
Yeah, so Prabhat, can you come to the first slide?
Yes.
Yeah. So I will. So briefly, we have a case of a recurrent urothelial carcinoma, which is uh, recurrent in at least T3 and 0, and definitely we have with multiple issues like previously hypertensive with MC infarct on medication and with deranged renal function. And so now we'll start the discussion going stepwise. So first, I would like to ask Dr. Sashank Saini that because this kind of patients first go to a urologist and uh, before MDT, the first approach is to a urologist. So with this background information, how do you approach the patient who are elderly with this kind of complaints? Dr. Shashank?
Good evening. Yeah, good evening. Hi, Dr. Bipinesh. Good evening to the panel. So this is not a very, I hope you can hear me. I am clear?
Yeah.
Yeah, okay. So this is not a very uncommon scenario what we see daily in our OPD at Mahamana. So quite a familiar scenario. And as you asked, what will be the first thing? So I think the thing missing in this slide is whether he is currently bleeding or not. That lays the foundation of how acutely you need to go in. Sometimes
So I
these
assume that
patients,
patient is needing blood transfusion, so he's having bleeding, which is controlled,
yeah.
but is not very well controlled.
Mhm. So, first of all, see, he is taking two antiplatelet. So, as soon as possible, we like to, and according to your MRI, he is having a T3 lesion. So, he needs a TURBT at least to control that bleeding. Only thing is, we'll want to know how soon that he can be taken up, because usually what we do is stop this. Baby ecosprin is allowed, but clopidogrel we need to stop the patient at least 4 to 5 days before taking in. So that's why I asked how acutely we need to take in. And usually this patient do have some kind of clot also. So that makes the situation a little more acute. And it is not added in that. Usually this will be accompanied by a raised creatinine or some hydronephrosis. As we can see, one kidney is
Mhm.
already knocked out on DTPA. The other might be having hydronephrosis with such a acute bleeding. So usually these are acute condition. After explaining to the bystander, we have to take these cases maybe next available OT, or as soon as possible when we get the fitness.
So in this patient, suppose we have done a TURBT and we saw that it's a recurrent special invasive. So you are planning for maybe referring for NACT and then surgery. So what is your approach? Would you think surgery will be good for this patient, or maybe you can send for CTRT, or maybe or what is your outlook regarding the patient with this kind of
I think
comorbidity
there
and
is
age is the same?
there is one ideal scenario, and there is what happens in the real world. So in an ideal scenario, seeing the previous slides, a frail patient with multiple comorbidities, I don't think he is fit for the classical GEMSIS or even Durva. I'm not very sure. EV Pembro, maybe Dr. Akhil can pitch in whether he goes into that. What we can give to him to make it.
We'll proceed to that. I'm just asking you out
Yeah.
whether you are
Yeah,
willing to go for
yeah,
surgery
yeah,
with
yeah. Yeah, first URBT and in a tumor board discussion to go for NACT, because T3 recurrent lesion, I don't think the disease is already systemic. So there is no fun going for upfront surgery in these kind of patient, and they are usually not well optimized. So upfront
Mhm.
radical cystectomy, not an option. TURBT, clot evacuation after stabilization, my first choice. And for a tumor board discussion for if he is fit for any kind of chemotherapy. If he is not, then a shared decision making with the patient and the bystander, especially the primary caregiver, the son, daughter, whosoever who lives with him, explaining them the risk of delaying the surgery because he's not going to get fitter by age. He's 73. Next year he'll be more sick, more compromised. So if they're ready under high risk, yes, a cystectomy can be done and should be done at high volume center like our. Otherwise, if they're not agreeing to the risk, then a maximal TURBT followed by, I'll ask Dr. Prashant or somebody, my radiation colleague, to pitch in and add some radiotherapy to it. And maybe EV Pemro, I'm not sure whether, I don't think he's fit for that. Doctor, you can add that. Yes.
Yeah, we'll discuss about that. So thank
Yes,
you,
yes,
Shan. So
yes.
before we proceed to the geriatric question, it's very important to know the plan for the patient. So with the MD discussion, whether the patient, how will the plan be? Because that gives us guidance regarding how to regarding geriatric assessment, what we're looking for. That gives us what we're planning. So now the patient is hypertensive and BP is controlled with, but he had a severe last year ischemic infarct and on patient with egosprin and clopidogrel. And also, next slide, please. Yeah, and also patient has renal compromise, although there are no features of hypertension nephropathy. So I'll ask Dr. Praveen, who is a physician with us, to comment on the what is the approach for optimization for a patient plan for further systemic therapy or surgery when they have multiple comorbidities which are not very well managed, along with factors like bladder cancer, which can again affect the creatinine and other renal function. Dr. Praveen?
Yeah. Good evening to all panel members. Regarding this case, he's a 73-year-old male with active hematuria and with a previous history of CVA 1 year back and hypertension. So he is presently on dual antiplatelets, so which is not recommended actually. So dual antiplatelet in a stroke is recommended for just 21 days. So post 21 days, single antiplatelet to prevent the further stroke is what the guideline says. So, since the patient is actively bleeding, having hematuria with anemia requiring transfusion, so we can stop antiplatelets and then correct the anemia since he has multi nutritional deficiencies like low folic acid, folates, and ferritin. So we need to correct these nutritional deficiencies and stop bleeding, which might be due to antiplatelets. So stop antiplatelets, correct nutritional this one status with folic acid and iron supplementation. And azotemia might be due to because of the obstructive nephropathy, which gets corrected once the hydronephrosis gets corrected. So these are my plan of action. And since the nutritional assessment is 18, so the patient is under risk of malnutrition. So that has to be taken care.
Yeah, definitely. So the optimization of the hypertensive and particularly the platelet drugs, because many times patients are on treatment for a long time and they don't want to change the medication. So it's very important to counsel them and particularly manage the polypharmacy in accordance with the planned treatment. So, and definitely in this case, anemia, which is multifactorial along with bleeding, nutrition deficiency and iron deficiency also there, which needs to be corrected. So next slide, please. Yeah, so next I would like to ask Joyita ma'am. So ma'am, we have you have briefly seen the way the geriatric assessment has been done. So how do you, in your practice, how do you start the geriatric assessment? Is it the same, or do you, in the first part of the screening followed by detailed examination, or do you think any change is required? Joyita ma'am?
Hi everyone, good evening and happy to be here. Yeah, so the geriatric assessment in every place as possible people are doing. So here the screening is G8, but usually we propose that we follow Indian scale that we have developed at AIMS New Delhi, that is the Scope C scale that has been validated on the Indian population. So Now, regardless of that, what I see here is G8 is 8. That is also something that shows us that we need to go for a comprehensive geriatric assessment. There are lots of points here where we need to focus. First is the patient is in risk of malnutrition, as Dr. Said before, Dr. Uh,
Praveen.
mentioned, and Dr. Praveen, sorry, mentioned before. And there is a history of falls, which is a very important factor that we look in geriatric assessment. And in the clinical frailty scale also, there the person is vulnerable. Frailty again is a very dynamic thing. We need to be very careful. And the MNA, risk of malnutrition, that these two are very dynamic things. So nutrition we have to build up. The frailty is there, and tug scale, okay, but IADL 4, there is some compromise in the functionality, and the others are mostly fine. Fatigue is also, there is some fatigue. Polypharmacy, yes, as he mentioned, there are two antiplatelets, and they have to be stopped. So these are the domains we need to look into. Social support, you said, is good, but we again need to see, we have to see whether we can talk to the patient or the patient party, the main caregiver, the financial issues, and whether the patient is ready to go into this the treatment that you have planned, the surgical treatment that you have planned, whether the patient can be taking into account. So these are the main things that we need to look into. From personally, I feel this is a very vulnerable patient, and we need to take care of the patient with care.
Yeah, thank you, ma'am. So for highlighting the option of scope C scale for screening, particularly for Indian patients, and also highlighting the various issues in the various domains. So next, as you can see in this patient, that there is a history of spontaneous fall, and tag is 17 seconds. So I'd like to request our physiotherapy colleague, Dr. Ankita Chitre, is with us to comment on the same about tug in this patient, and how is it related with the spontaneous fall, how it can be correlated with the same. Ankita Chitre,
Uh,
please.
yes, good evening, Bipinesh sir, and thank you for the panel discussion. And am I audible?
Yeah, yeah.
Yeah. So as I see, the IADL is also reduced, and the tug is 17 seconds, which we take the normal as 10 seconds as per the study. So tug does not only talk about the gait, but it also talks about the lower limb strength. Here, when we see the muscle power is given post CVA as 4 by 5, that is the manual muscle testing grade. So even that will play a role, since the muscle power is 4. There may be a possibility that due to that, the time of the tug is increased. So the time from which the patient has risen from the chair is maybe a factor which has influenced the duration of tug, and of course then the gait again. So that can be one factor. Again, he's IADL dependent also. So majorly is we will focus majorly on the lower limb strengthening, which can improve the tug, that is reduce the duration of the tug, and also can improve the gait speed.
Yeah, thank you, Ankita, for highlighting the issues, particularly with regards to mobility and lower limb strength, which can affect this patient's history of fall. Because in the CARG score, there are 3 points for the same, and we need to assess properly what causes spontaneous fall, what is really spontaneous, or the other factors
Yes.
to be corrected.
Maybe we
So,
can, if since they have a history of fall, we can also work on the fall prevention strategies, which are there for the geriatric population. So there are like 4 strategies. So we can work on the hip, ankle, different strategies, and then reduce the chances of fall, as well as do a little modifications in the intrinsic and the extrinsic environment of the patient as well. So environmental modifications can also be a crucial part.
yeah.
I
So,
see one question down, that
yeah.
power 4 to 5 affects getting up from the chair to what extent? So, muscle power again, 4 is minimal 4 the grade is minimal resistance. So that can be one possibility, that there is a residual weakness. So basically that
Yes,
can
so
be
in this
not to
patient,
a
it is not
greater.
particularly affecting it. The patient is able to, with some minor support, patient is able to get up from the chair. That's not a big issue for the patient.
Yes, so there was a question that how, to what extent. So not a major extent, but that can be one factor which can limit getting up, because that is also one point that the patient has to arise and then again descend on the chair.
One more question. Purvi sir asked that if the muscle strengthening started, so in how much time it will really affect the tug testing to be improved?
So minimum, as per ACSM and the American College of Sports Medicine says that at least 3 to 4 weeks of a strengthening protocol is required to see a definite change in the strength of a individual. So approximately we can repeat the tug probably after 3 to 4 weeks. That is the minimum. Maximum can be at least 6 weeks to see a good amount of change. So that is why whenever we prescribe supervised exercise or home protocols, we tell them at least a rigorous training of 4 to 6 weeks is mandatory.
Yes. So thank you, Ankita. So now we have another dietitian, Dr. Anita, with us. So Dr. Anita, I would like to ask you a few questions. That first, already Joyita ma'am has highlighted the various domains in this patient. Would you like to add anything extra? And your comments on the CARG score as a reflection of the comprehensive geriatric domain, what it particularly for this patient, does it reflect the comprehensive geriatric evaluation or does it not? Anita? Dr. Anita?
Yes. So, this, of course, the patient is vulnerable in this case, and so we must ideally not give a full dose chemotherapy. The CARG score helps to determine how much of chemotherapy when given and what is the percentage of risk for the patient. So therefore, we full dose chemotherapy should not be given as much as possible, and
Dr. Anita, you got muted. Yeah, please go ahead.
so the patient is fragile, in my opinion. So we must, and because of the nutritional deficiencies, so we must reduce the chemotherapy dosage and give the patient.
Okay. Dr. Prem, you wanted to add something?
Just a couple of points before. I mean, I know it's already 7:25. So one is the person also has anemia, so that has to be sort of factored. So that will cause a bit of fatigue. And secondly, was the person on catheter? So if the person is on catheter, also, I mean, after hematuria, was the person on catheter or not? Because that also can hamper the physical activity. So I mean, just two small points. I mean, you can proceed because we are sort of have to discuss the case and get into the second one also. Please, just quick comment.
Yeah, thank you, Dr. Prem. So, and I'll go to the medical oncologist, Krupa Shankar, sir. So now we have a geriatric assessment done and opinion from the various teams of the geriatric discussion. So how do you approach, what will your plan for this patient? Krupa Shankar, sir?
Yeah, hi, Dr. Bipinesh. Good to hear from you. So I think very clearly this patient is definitely not going to be cisplatin eligible. So, he's going to be cisplatin ineligible. So, that really cuts down on our options as far as neoadjuvant therapy is concerned. And again, obviously fitness for surgery as well is a question mark here. So, this patient is not going to be fit enough for radical cystectomy as well. So we're looking at a bladder preservation strategy here as well. So for that, I would probably lead in with EV or enfortumab vedotin plus pembrolizumab if the patient has got no financial constraints. That would be my number one go-to choice. Else, the other option would be, based on phase 2 data, to do only IO and probably substitute carboplatin if that's feasible. Would look at doing that as the next option and then taking them up for concurrent radiation or concurrent CTRT after that. So I think that would be my working algorithm for this patient, because given that, his CARD score is high, and he's at a higher risk for developing chemotoxicity, would not be able to give him. He's cisplatin ineligible. And the other thing is, as far as EV is concerned, we know in the neoadjuvant setting, it's not yet approved, but the phase 3 data is already there, based on the EV 302 data as well. So that again, we have a specific set of criteria where we look at just how we look at defining cisplatin eligibility versus ineligibility, where we talk about ototoxicity, neurotoxicity, and nephrotoxicity. Apart from that, NIHAP or New York Heart Association class heart failure of anything more than grade 4. So apart from that, we have something called EVITA criteria, which looks at selecting patients for enfortumab vedotin as well. Just 5 points. One is the HbA1c more than 8. I mean, there are a lot of criticisms about this EVITA criteria as well, because they're not set in stone. They are reversible. Because if you look at the Indian population, majority of them will have HbA1c of more than 8. Doesn't mean that it can't be controlled. It can be controlled. So these are not absolute criteria. This is just something to guide us. Yeah, and again, just not just based on your HbA1c of more than 8. Somebody's got pre-existing grade 2 more than sensory neuropathy, then also you can look at using EV. And again, if the CC is less than 45, that's also part of the EVITA criteria. And then performance status of more than 2, and anybody with any corneal toxicity or corneal opacity, be it from pre-existing diabetic retinopathy as well. So these are the 5 points that are included as part of the EVITA criteria, just like how we have the cisplatin eligibility criteria. So I think that would be my go-to choice here for this definition.
Yeah, if the patient is not affordable for the EV plus, so because we also use EV plus Pembro option. So although it's not, it is the data is evolving very soon, and we might have the data soon. But we have seen that EV plus Pembro is a good approach. But if the patient is not financially feasible for the same, what will be your chemo option in this setting?
So yeah, I would probably look at doing carboplatin, albeit there's no hard and fast great data for carboplatin in the neoadjuvant setting. But nevertheless, I think you've got to individualize it to this particular patient. So I would look at doing that. Or even there is phase 2 data of giving just IU alone. The pure O2 data for pembrolizumab and the abacus data for atezolizumab. And if you look at that, I agreed that there's only phase 2 data. But in that sort of a setting, I would definitely look at doing that as an option as well. I would do shared decision making, sit down, talk to the patient, explain the pros and cons, do a shared decision making, and then go ahead and choose. If not for EV plus Pembro, I would look at doing IO based regimen here, based on phase 2 data, like I alluded, where again the path CR rates are close to 30 to 40%, albeit with the caveat that it's only phase 2 data.
Yeah, definitely. So thank you. So with the discussion, we have two options: EV plus Pembro, with very good data coming up, and also with our personal experience in our center, we have used in similar settings on some patients, and they have done really well. So if that is not feasible, definitely carbo-based chemotherapy is the only option. Or as was highlighted, one immunotherapy combination. Also, we have phase 2 data. So now for this patient, I'd like to ask the radiation oncologist, Trinanjan Basu sir. So now, suppose the patient is not fit for any of the regimens, or has been given only immunotherapy. So what will be your further approach regarding the chemo radiotherapy or only radiotherapy? Trinanjan Basu sir.
Yeah, hi. So if the patient is not fit for radical CTRT, which looks like as bladder preservation, then if you're doing some immuno, then this also brings doing some sort of RT dose, because that will only help the immuno also. So we have good data in last 2 years ASCO. There are a lot of weekly hypofractionated data for bladder. Bladder long been now changed to, we used to do about 6 weeks in bladder preservation. That has already come down to doing 4 weeks, and also weekly ones. So weekly ones, there are data like 30 gray in 5 fractions, 36 gray in 6 fractions, and we have done it. And in fact, from our center, we already have published for initial 5-6 patients data. It's got APGCO. It will just come out in the next issue. And these are approved for geriatric patients. There's one international geriatric radiotherapy group, and we are in process of writing a manuscript for this chemo ineligible, eligible for IO, because bladder is a disease of 70s and 80s. So doing this weekly hypofractionated. So I would put this patient, if they're receiving your EV plus Pembro or Pembro, in ASCO 23, I guess Akhil would remember, there's one data presented also of Pembro and weekly 36 and 6. So I'll put this patient for that regime in our center for 6-7 patients, and they have excellent hematuria control, excellent pain control. They go off catheter by after about only 2 sitting, and though it's quite initial result, but they tolerate well. If not, BC 2001 and Beacon long-term data that people need concurrent chemo. If you're not able to offer concurrent chemo due to all the geriatric assessment and other issues with the patient, then tweak your radiation regimes. Make it 4 weeks or do weekly once for 5 to 6 sittings.
Yeah, thank you, Dr. Basu sir, for highlighting the very good data which is there, and also which needs to be highlighted for more users in this population. Now, Dr. Nandini Menon, ma'am. So, in the same patient, if we have to use a regimen as concurrent with radiation, what will be your preferred regimen with the history of this patient? Nandini, ma'am.
I think we've already just discussed just for neoadjuvant, just like in neoadjuvant, this patient is definitely not cisplatin eligible. So the common concurrent regimen we use in such patients is gemcitabine weekly. So that could be an option for a concurrent therapy. I wouldn't want to give this patient cisplatin. So that is one of the alternatives that we use.
Also, I would like to highlight about the mitomycin 5FU data, which is there, which can be utilized, but 5FU infusion is also likely to be issue. But the good thing about this patient is presently the cardiac parameters are good, so we can consider and discuss about mitomycin 5FU protocol as well, which is also an approved treatment option, and there is a large RCT, phase 3 RCT of mitomycin 5FU as concurrent versus RT alone, which showed a significant survival benefit. So that is also will be one of the option. Though I completely agree with Ma'am Nandini ma'am that in the usual routine treatment, most of the time we end up utilizing either gemcitabine or sometimes carboplatin as a concurrent regimen without large and strong database.
Yeah, definitely. So I think we are short of time, and definitely once we see a geriatric patient, and we evaluate in detail, we see so many issues which need to be discussed, and when half an hour to 1 hour becomes short for the assessment and discussion of the same. So to summarize, definitely this patient, a vulnerable elderly male with definitely multiple comorbidities and anemia due to bleeding and nutrition deficiency and deficiency with various high risk for surgery, and also based on discussion, the two options which are most feasible for this patient will be EV plus Pembro if feasible, followed by assessment for surgery, or if it is not feasible for that, then the chemotherapy based treatment along with assessment and modification for all the domains in which we can offer definitely some interventions for the patient so that his quality of life and tolerability is increased. So I'll hand over to Dr. Akhil for any final comments on this case and for the next case.
Yeah, so I think this case was well discussed, and we could cover most of the relevant geriatric assessment points beside the routine medical radiation and surgical perspectives. So this is one of the case which highlights the actual need of geriatric assessments and integration of geriatrics into the real practice. So this is actually a real case. This is not a made up case. This is a real case, and we ended up using in this patient actually EV plus Pembro, and thankfully after that this patient was considered for surgery. However, it was still high risk for surgery. Patient opted for radiation, chemoradiation, and the patient was given concurrent radiation and with gemcitabine, and after that patient is on maintenance pembrolizumab at present. So I think such cases highlight the importance again of discussion involving your teams optimization of the patient is really important, and we need to keep that in mind. Simple things as anemia control, anemia correction will add significant reduction in the fatigue and improvement in overall quality of life of the patients. This is valid not only for curative patient but also for patients who are being planned for palliative intent treatments. So all these small points actually change the treatment options, change the way the patient perceive the treatment, and they have also significant improvement in their quality of life. So I think quality of life has become the most important parameter these days, and in our all studies we are trying to include these parameters. Yeah. Any additional comment from our geriatric team, and then we will proceed to next case. Joyita
Yeah,
ma'am.
I just wanted to add, you was just going to tell that the quality of life, because in this patient who's very vulnerable and we are not able to go, 100% in the treatment, we should actually focus on the quality of life and look into the geriatric domains. Here, like you said, taking care of the anemia and the nutritional assessment we have seen. Risk of malnutrition anytime can go into malnutrition and the cancer-related cachexia. That time we cannot revert it back. So looking at the nutrition and, as Ankita said, the physiotherapy, a little bit of counseling, a holistic kind of care, palliative and supportive care is very much required. Shared decision making, as Dr. Basu said. So all these things are very important. Talking to the patient, understanding what his thoughts are. Patient and the caregiver is very difficult in our situation, but still we need to talk to the patient, understand what he really wants, and his caregivers, the near and dear ones, what they really want. This type of holistic care goes a long way in improving the quality of life, which is so important.
Thank you. Thank you,
Thank
ma'am,
you.
for the comment. I think, again, we move to case two. We have Dr. Shreya Srivastava. I request her to present this case.
Good evening, respected teachers. Sir, could you please share the slides, sir?
Yeah. I think I was sharing, but Himanshi shared it, did something. Himanshi, did you disable screen sharing for me? I don't know why.
Yes, sir. I shared the intro slides, sir, for ma'am.
Okay. It's not needed. We don't need to interrupt for formalities. Yeah. Okay. Yes, let's go ahead. Yeah.
A very good evening to all the respected faculty members. Continuing with the momentum, the second case is of a 67-year-old female who came with a complaint of dysphagia for 4 months, weight loss of more than 7 kgs over the past 3 months. Upon evaluation, a base of tongue lesion was found, and upon CT head, neck, and thorax, left base of the tongue lesion, a 3 into 2 centimeter mass was seen, with a single lymph node of 2 into 1 centimeter on the left side was seen. So a diagnosis of CT2N1 disease of base of tongue was made. Upon biopsy, it was squamous cell carcinoma, P16 negative. She was also diabetic since past 8 years and was on glimepiride 1 mg and metformin 500 mg BD. So upon workup for planned CTRT, hemoglobin was 10.8, the transferrin saturation was 25%, serum ferritin levels were 132 nanograms per ml, creatinine was 1.1 and DTPA GFR was borderline 54 ml per minute. Serum albumin was slightly low 2.7, HbA1c was 8.9, a poorly controlled diabetes, and other routine lab investigations were within normal limits. Upon echocardiography, the ejection fraction was optimal, 63% LVEF, and pure tone audiometry was also normal. Since this patient is elderly with comorbidity of diabetes, a geriatric assessment was done. From the general details, we could find out that the patient is a housewife with no immediate support. The children stay far away from her. Anthropometric examination showed a height of 146, weight 45 kg, and optimal BMI of 21. CFS score was 2, but the G8 score was 11, which warranted a comprehensive geriatric assessment. So the next slides. The various domains assessed were nutrition, where the BMI was 21, mini nutritional status was 15, low, physical function IADL was 5 by 8, with no history of spontaneous fall. Mobility tug was 21 seconds, which was low, psychological GDS 2, cognitive examination showed an MMSE of 28. Fatigue was 2 by 10 on numerical rating scale. Polypharmacy, two meds only, metformin and glimepiride. Vision, there was no difficulty in near or far vision, and there was no impairment on hearing. So upon the CARG scoring, the positive scores were for polychemo full dose and inability to walk on block. Chemotherapy full dose, the grade 3 adverse effect was 6 to 44%. For chemotherapy reduced dose 4 to 30%. Monotherapy full dose 4 to 30%, and monotherapy reduced dose was 2 to 19%. Thank you.
I would just like to correct that the scoring is not 6 to 44. The score is 6 and it denotes a 44% risk.
Yes.
So that
Sorry.
correct.
Yes, sorry.
Yeah. So this is important. We also mentioned the score and then percentage. The apps usually give directly percentage, but as we realized, Dr. Bipinesh maintained in all our files actually the points which are leading to reduced scores actually. So that is our protocol now based on Dr. Bipinesh guidance. We are now following that. We are maintaining scores because the scores are more important than getting the exact percentage. As you start using the scores, you will become more confident utilizing the scores. But it might be slightly different when we are starting afresh. But yes, that's an important point. So I think I will come back to my physician, Dr. Praveen. Dr. Praveen's assessment is very important for us, and I request most of the time to get his comments before we start planning any treatment. So, Dr. Praveen, requesting your comments in this case. This is a 67-year lady. Yes.
Yeah, definitely. So, good evening, Dr. Akhil. This is a 67-year-old lady with a carcinoma base of tongue. So, the issue is she has got significant weight loss of about 15% with malnourishment and MNA of less than 14. And the thing is she's diabetic since last 8 years on glimepiride, which is a insulin secretagogue, and metformin of 1 mg and 500 mg BD. So the issue is because of the poor oral intake, the lady is more prone for hypoglycemia. So my aim is to reduce this hypoglycemia risk and improve the HbA1c. So according to ADA guidelines, here the patient comes under intermediate risk for hypoglycemia. And the target for this patient is around less than 8.5. So the HbA1c is 8.9. So we need to just reduce by 0.4%. So what I would like to do is I would like to stop glimepiride, which has got a higher propensity for hypoglycemia, and start on the medication which is safer for him. So for her, so DPP-4 inhibitors with metformin would be sufficient since the patient is alone and she has no caregivers, as been mentioned in the case sheet. So I would like to continue her on OH and not start her on insulin right now with a target HbA1c of less than 8.5. So I would like to start her on a DPP-4 inhibitors like sitagliptin or vildagliptin or linagliptin, and stop glimepiride and continue on metformin. And since our nutritional status is also on this one with the hypoalbuminemia, so we need to look into that also with high protein diet. So these are my suggestions.
Yeah, I think
And also, there's one more point. Since she's diabetic and on most probably going on chemotherapy, so I would like to emphasize on the vaccination, so which is very less prevalent in the in our society. So we need to promote adult vaccination, which is very much essential. So what we do in our setup, as Dr. Akhil, so we are starting the four vaccine, like pneumococcal vaccine, and then influenza, and then Shingrix vaccine.
Yeah.
So this has to be given for this patient.
Yeah, I think this vaccination part was not covered in previous discussion, and Dr. Praveen raised a very important point. We aim to give vaccination to all our patients because these patients are significantly prone for not only pneumonia but also even herpes infections. And the good part is that herpes vaccination is some now much easily available and being utilized. So wherever it is feasible, I think we try to utilize it, especially patients who are diabetic. This is our protocol. In all diabetic patients, we try to incorporate it because these are patients are at significant high risk of developing herpes during their treatment or just after treatment because they will be more immunocompromised during part.
And second thing
Apart
is
from that, I
nowadays with
think
the availability of
another point that
pneumococcal vaccine,
yeah,
sorry to interrupt, with the availability of PCV20, so which is just a single dose, so it is very much feasible and accessible right now.
yeah. So I think as Dr. Praveen highlighted, a single dose vaccination for pneumococcus is available that will help. Besides, one more point of this patient is long-term diabetic. So any assessments for long-term diabetes, I think that should also be included.
Yes, definitely. So, her target organ damage has to be done with creatinine, urine creatinine ratio, fundoscopy. Since patient is also has got a diabetes of 8 years, so annual assessment of target organ damage like annual ACR, then fundoscopy and ultrasound kidneys has to be done.
Yeah. So this is really important actually because this patient has TTP-GFR, which is good, fine enough, not very good, but still fine enough to give weekly cisplatin most of the time. But still, definitely we have a concern that the patient has already diabetic nephropathy set in because this is already 8 years of diabetes. We would like to get USER. As a medical oncologist, I would be very keen to look at reflexes, at least deep tendon reflexes, because this patient is likely to have some amount of neuropathy already set in, and this is important. I will take comment from Dr. Basu now. Dr. Basu, when you see such a patient and you are planning definitive CTRT for such a patient, what concerns you as a radiation oncologist when you are planning treatment?
So we need see this is quite a curative cohort. If I other assessment are in place, if I assume the uh, the disease related aspect wise, this is early stage 3. So this has high chance of cure, though being P16 negative. Mm, I would be concerned whether because the until now for P16 negative based on whatever the surgeons debate about some role of robot, it's still not full proven, so it remains with radical CTRT.
Yeah, yeah.
And an average P16 negative even stage 3 has good chance of 25-30% local failure. So I'm concerned about failures. I'm also concerned that the patient should receive, like you rightly said, an optimal CTRT. Like, I know that will have a bearing if someone is not able to receive the optimal doses of concurrent chemo, be it we do 3 weekly, probably we'll do weekly only for this patient. So that also has to receive an cumulative 200 milligram meter square with the full dose of radiation. And then of course the radiation nitty-gritties, I in this meeting will not go into the radiation nitty-gritties, but I would want a decent quality IMRT with probably an image guidance daily or at least 3 times a week. Take care of the diet, take care of a proper weekly review.
Yeah.
So our aim, Akhil, goes that what we plan, we are able to deliver by managing all these things.
Yeah. So I
One
think,
very important of I would also like, if feasible, to do a swallowing assessment.
yeah.
Um, because based on 67 diabetics, uh, they will they will get some grade 3 Akhil, your screen.
Yeah, yeah, yeah.
Yeah.
I think yes. So thank you, Dr. Basu, for the important comments. As I think as Dr. Praveen also highlighted and you also highlighted about the nutritional part, this patient already has more than 10% weight loss from the at the baseline, and we need to be very careful. I think I will take comments from our geriatricians. Dr. Anita would like to uh, add a comment about the nutritional part in such a patient where
Yes,
the
yes. Can
patient
you
is already
go
having
to the next slide,
hypoglycemia.
please? Yeah, geriatric assessment slide. Yeah, so basically, the patient has dysphagia since 4 months. So there's a high likelihood that he will or she will also have some kind of nutritional deficit. And we have done the MNA score, which is 15, which means it is poor. She's a housewife. She lives alone, so most likely she has ignored herself completely. Her CFSS2 G8 is also how much was the G8? I think it was
11. 11.
11. So basically, G8 less than 12 means warrants for a complete for CGA. The IADL is also affected, which means she is not able to do much work on her own, and there are a lot of instrumental activities of daily living which have been affected. The TUG score also is bad, which is 21 seconds. So anything above 13 seconds is not good, which means there is a high chance of fall. This lady lives alone. Probably she may not be well to do, and she's probably because of her cancer she's ignoring because of her illness she's ignoring herself, and she's unable to perform her daily activities, so that will lead to a further downfall. So hence more attention needs to be given to such a patient.
Okay, okay. I think the she definitely requires a lot of attention. A lot of social support is also required, and the
Yeah.
patient, that is a problem here. Contrary to the previous case, the patient had good social support despite having multiple comorbidities and on multiple medication. This lady seems to have somewhat better points, but still social support is poor, and tug is also slightly worse, despite no spontaneous falls history. So some points are good, some points are poorer as compared to the previous case, and we need to be extremely cautious because the patient's treatment will affect the intake, which is leading likely to reduce. Uh, and we know that during CTRT, the patient will have at least grade 3, grade 4 toxicities, and they are expected to occur during the third and fourth weeks of the treatment, where the patient support requirement will go much, much higher, and she might require inpatient care as well during that time. So I think now we know during the waiting time for starting of chemo radiation, again, we'll take comments from Dr. Krupa Shankar firstly, or he will consider any other treatment option. DTPA-GFR is fine enough. Dr. Krupa?
Hi, Akhil.
Yes.
Good to hear from you, mate. Yeah. So, no, I think this patient, I'll be very cautious about going ahead with platinum. I mean, like, because it's borderline. I mean, like, definitely not 3 weekly, definitely not 3 weekly platinum. Choice boils down to either weekly platinum with nimotuzumab or, your EGFR mab, like cetuximab is another option as well. If I feel the patient is not going to be able to tolerate weekly platinum. And again, now you have the data as well for weekly taxane, or the docetaxel as well, in cisplatin ineligible patients. So that is yet another option. But here, my first choice would be weekly platinum plus or minus nimotuzumab. And if not for that, then cetuximab would be my second option. And my third option would be docetaxel, in the order of preferences for this particular patient.
Okay. Okay. That seems quite reflecting of the real world scenario, I think, and as per the choice of most of the medical oncologist and with the availability of the data, I think that matches. Thank you. Thank you, Dr. Rupa. I think also the choices are quite similar in our settings as well. Also, sometimes we will consider, for example, in any patient where patient is fit enough for cisplatin, we'll start with cisplatin, but somehow if the patient is not tolerating, then we might to switch also. So this has happened sometimes, but yes, I completely agree that this patient is definitely high risk of clear deterioration in both kidney functions and overall general well-being during CTRT. So this is what is expected. So again, coming back to Joyita ma'am, your comments, whether do you think the assessment is complete? Any other point which we are missing or which we need to stress upon apart from the nutrition and physical functions being addressed? So your comments will be helpful, ma'am.
Yeah. So I was looking at this case, and I think this is a very vulnerable case actually. The point that you made, that she has got nobody to look after her, the support system is not there. And I am not sure. I feel the socioeconomic status is also low, maybe. I'm not sure, but I feel it is. So maybe she is a single woman who's working and taking care of herself, some kind of work, which will be hampered a lot. The socioeconomic status has to be looked into here. How she will be supporting her treatment, who will take care of her after that, because this is a long trajectory, the treatment. She is malnourished, she has functional deficits, she has no support, she's diabetic on an inappropriate medication. She is a very vulnerable patient. And
Right.
another thing that I wanted to ask is about her symptoms. Is there there should be a role of palliation or supportive care? What about the pain part? What about the quality of life? Inability to eat, tumor base of tongue, there should be inability to eat. So these kind of supports, how are we looking into it? The palliation part, the supportive care part, the quality of life, somebody to talk to her, some counseling, these kind of things I was
Yeah. In fact,
I wanted to know about it,
yeah.
all these
Also,
things.
the patient will require hand holding.
Yeah, yes,
Yes.
definitely hand holding, yes.
Yeah. So actually, that is why this patient was considered for strong support with our
Mhm.
social worker team,
Yes,
and our
social work.
social worker team takes care of these parts, and
Mhm.
also the patient was given an option to shift to our hospital's dharmshala during for the entire treatment part, so that it can be taken care of instead of going back forth and home from home every week and every day. Though her home was not very far away, but
Mhm.
we gave her option, and the patient chose to stay in hospital's dharmshala,
Mhm.
where not only additional care for the same. So I think that is very important. The social support and hand holding in such patient becomes very, very important, especially considering the
Yes. Mhm. No, it is commendable.
poor
Actually, it is commendable.
family support.
Mhm.
That is very important.
Yeah,
Thank you.
good
Yeah,
social
yeah.
worker.
Thank you, ma'am. This is very important point to be highlighted. And most of the time in busy OPD, as a medical oncologist or radiation oncologist, we might miss these
Yes.
points, but
Mhm.
thankfully we have a strong team to support all these points.
That is really good.
And the nutrition part is definitely very important. I think this patient required a RICE tube placement at the baseline itself, because our nutritional team, when the patient was seen in geriatric clinic, the nutritional team discussed putting up the RICE tube. Initially, the patient was not very willing, but when we counseled 2 or 3 times, different doctors counseling multiple times, the patient understood the importance, and RICE tube was placed, and her weight loss was stabilized. And over the 2 weeks time when the radiation was being planned, the patient's weight improved somewhat by 2 to 3 kgs, and that helped actually during the treatment. So I think that is very important. Early introduction of Ryle's tube, especially when the patient has already a weight loss of more than 10%. I think that is important. We are approaching the end of the
Akhil,
time
uh,
allocated.
Akhil,
Any
can I
final?
make a comment?
Yes, ma'am. Yeah, ma'am.
Two,
Please
three
go.
things I wanted to add was that the concurrent chemotherapy, I completely agree with Dr. Krupa Shankar, but just a caveat to two of the things that was discussed. One is cis-nemo. In the cis-nemo study, the benefit of the progression-free survival with the addition of nemotuzumab was not seen in the elderly subgroup, which was a post-hoc analysis done because of the increased toxicity. So that is one thing we need to keep in mind, that I think nemotuzumab is an excellent addition, but if you have an elderly frail person, intensifying with a second radiosensitizer in that study did show some increase in the toxicities. if I remember correctly. And the second is in this patient, docetaxel as an alternative, I would be a bit concerned because even in our study, which had
Yeah.
dosi versus RT, in patients with low albumin, they were the ones who actually got a lot of adverse events. So that is
It's a lot
something
of
that I
interest.
would be a little
Mhm.
cautious with in this group. And just like you said, NGT insertion preemptively for such patients and correction of anemia before starting CTRT, because usually we have a waiting time of 2 weeks in which all these factors can be addressed. And most important, like you said, keeping her in a place which is accessible for supportive care. Probably in this patient, we could we may be able to deliver cisplatin if we like follow all this.
Yeah, Dr. Akhil, we have some questions in the chat box. You can.
Yeah, Dr. Prem, please go ahead.
Yeah. So Dr. Purvish is asking, is this lady actually working for a living? Unlikely to him, according to him. Then do we know how the cost of living was handled, and do do every use feeding jejunostomy in NHSCC feeding right? So if you could address those questions. Yeah.
Yeah, I'll take the first two questions. So actually, this lady, she was not working for a living. The children were working outside of the state, and that is why she was alone. But they were partially supporting the treatment of the patient, and also patient had enrolled in Ayushman. Uh, Dr. Kil, can you comment regarding the feeding genostomy part? I didn't get the question exactly.
So I think feeding jejunostomy will considered in as a palliative intent treatment. This patient was planned for definitive intent CTRT, and if the patient would not have been considered for a definitive CTRT, feeding jejunostomy could have been considered, or placing when actually when we try to avoid, because that might be sometimes problematic and doesn't gives when there is an even when the feeding rice tube is through a nose, but I think patients will prefer that over feeding jejunostomy. Definitely, if the patient is for palliation, option of both is given and the patient is allowed to choose, I think. Sir, you want to add anything? Purvi sir?
No, I just wanted to ask you that question because
Yeah.
we in PMH we used to use a temporary feeding jejunostomy for
Okay, sir.
the duration of the radiotherapy, concomitant chemoradiotherapy, and till the patient recovered from the mucositis.
Okay, okay, okay. I think presently our focus,
Fair enough.
we utilize more of Riles tube, sir, in
Right,
present
right,
practice. But yes, that is all definitely an option, sir.
right, right.
Yes, sir. Any other final comments? Because we are ending, we are already
Thank you very
overshooting
much,
the.
Akhil. Thank you very much, Bipin, and your entire team. I think this was one of the most productive panel discussions, and both the cases have a lot to teach us, especially in the second case with a lady living alone, having uncontrolled diabetes, and then what is it to be used for controlling the diabetes, whether insulin, why insulin should not be used, what vaccinations to be given. I think that is exceedingly important. And so also in the first case, which was totally different with tremendous amount of support from the caregivers, what are the factors that would affect a patient who's frail or whose tuck time is prolonged, and how do we actually improve the leg strength, and what time duration we have to give before we see the impact of the exercise on the mobility of the patient. These are some very important takeaways that I have. In the second patient, I was just wondering whether any alternate medicines were being used by the patient, either for diabetes or for the head and neck cancer. But that was just a curiosity.
No, sir, it
Otherwise,
was not visible.
okay, fantastic. So thanks very much. I
I
think
was
this is
also
a
curious about, one thing about
uh,
the second case. There must have been some pain, I mean, the symptoms. So, is there easy availability of oral opioids? How is the palliation done? Can you say a little bit about it? I mean, the symptomatology, how do you take care of such patients, the
So
palliation?
actually, the good part is that all the opioids are available in house in the hospital, and this can be prescribed not only by the palliative team but also by the any of the oncologists treating the patients. And we utilize a lot of morphine. We utilize buprenorphine patches in a lot of patients, especially who are not able to take it very frequently by the clock, because we see morphine administration is depending on individual person, and if there is no caregiver, we are more towards utilizing patches in small, starting with the lower doses and going above. Yes, this patient required a patch administration during the treatment because the patient had significant mucositis as expected because of the disease burden. And so this is important comment, and we need to utilize opioids at the correct time in the correct way,
Excellent, excellent.
so that
And
the
before we
pain
sign off, I just
is
want to remind everybody.
optimized. Otherwise, these patients will not do well and will.
Thank you very much, everybody. And I want to remind you that next month on 12th of February, it is Dr. Tarachan Gupta and his colleagues from Bhagwan Mahavir Cancer Hospital who will be doing this tumor board. So once more, I invite all of you to actively participate in the same. And I thank you on behalf of AGOS and Dr. Prem for doing such a wonderful session today. Thank you very much.
Thank you.
And good night, everybody.
Night.
Thank you, sir.
Thank you.
Thank you.